Thanks for tuning in to our webinar series, In Case You Didn't Notice. My name is Pastor Darren Brake, Associate Pastor at the House of the Lord, and In Case You Didn't Notice is a partnership between the House of the Lord and Summit County Community Partnerships, made possible with the grant from the Ohio Department of Mental Health and Addiction Services. In this first installment, we will hear how addiction affects the brain from Dr. William Goldman. Stay tuned.
Thank you, Pastor Darren. In America, there is a rise in what's called deaths of despair, preventable deaths due to suicide, opioid, and other drug overdoses, and deaths related to poor behaviors. The United States is the only rich country in the world where mortality rates are increasing rather than falling. The underlying causes of deaths of despair are economic, political, mental, emotional, institutional, and of course, spiritual. Despair must be addressed in a comprehensive way, and the human spirit is an integral part of that complexity. So the church sits at a unique crossroads of all of these forces and is able to offer comprehensive perspective and insight towards supporting those people who are decimated by despair or who need help when it comes to dealing with substances. So we're glad to be a part of the discussion. I think this is a very important thing to be doing. And let me pray for what's going to take place today. Lord, we pray for the presenter. We pray for all that are watching. We pray that and thank you for the opportunity to have discussion and to have interaction like this, that we might be able to learn, prepare ourselves, and to face whatever it is that might be could have a potential of undoing our health, so that we might be able to live the best possible lives we can live in this situation. So we thank you now. We place this whole time in your hand, and we pray it in his name. Amen.
Amen. Thank you, Bishop Johnson. Just want to make a couple housekeeping announcements before I introduce Dr. Goldman. First, this webinar is being recorded, and it will be posted later on to the House of the Lord YouTube channel. Also, at the end, you will have an opportunity to ask some questions. We'll have a few minutes for some Q&A. So right now, I'll introduce our speaker for today's webinar, and that is Dr. Goldman. Dr. Goldman did his undergraduate work at the University of Georgia, Athens, went to medical school in Chicago College of Osteopathic Medicine, Midwestern University, did his residency at General Pediatrics and Children's Hospital and Medical Center of Akron, and his fellowship in addiction medicine, St. Vincent Charity Medical Center. Right now, he is the Akron Children's Hospital Addiction Service Program Medical Director, as well as the Silver Maple Recovery Medical Director, the Glenby Hospital, as well as Akron Children's Hospital Site Director, Urgent Care System in Boston Heights. So Dr. Goldman is, as you can see, he is very well qualified to speak to our audience and everyone today. So at this time, I'll turn the webinar over to Dr. Goldman. You can take the floor at this time.
Well, thank you for that introduction. I appreciate it. Makes me feel like I've lived a whole life. So let me see. Show screen, I think, is what I have to do. Okay, show addict. So yeah, thank you. Now you can see my screen with me. So yeah, I always, whenever I'm feeling down, I always say, if you're ever interested, go to YouTube and you can pull up all the old PSA ads that we've done, because that's about what we used to think about the disease of addiction, you know, saying crack kills, or just don't do it, or this is your brain on drugs. But we really didn't talk about people for who they really are, and who they, who we know that are loved ones. So just saying, if you ever need a good chuckle, that's where I come from. That's what they taught us when we were kids. So yeah, again, I am the medical director of Akron Children's. I also, a little bit that I kind of discussed when we started. I kind of got started in the field because I worked in the emergency room, and I had a young person who I always say came in saying, I'm a heroin addict. I need help. My brother's in jail. If you don't help me, I'm not going to be able to make it the day. And I started making phone calls, and at the time we didn't understand the disease, and I basically made some referrals to other institutions saying maybe they can help you better than the Children's Hospital. But you know, I think that was a real moment for the hospital to kind of learn. And so what telling somebody I couldn't help them, you know, what was found out is there was many of us actually who felt this way. And so the hospital, we started what we call a steering committee to look at what we could do better as an institution. There was interest in helping people, and kind of move from there. And so through a process of our staff, our foundation, you know, philanthropy, we were able to start a program and really work on trying to change some of the stigma, which we'll talk about today, and really help have a program. So now we do have, as of May 19th, we have an outpatient service to help under 18. People say, why not older than 18? Because at that point you're an adult, so we can help you facilitate you to adult programming that's available. But you know, we basically, if you work in the field, you know, you try to meet people where they are because that's what they need. So when Daryl came to me and said, hey, would you like to do a presentation? I said yes, because I think, you know, of all the things, talking about this disease, talking about the role of, specifically of spirituality is such a vital part of what we do. When I described my career, you know, I said, you know, everybody always thinks, oh, you go to the doctor to get medicine. And I always say, this is the only field I've ever been involved with where I say you have to believe in something else. So I always joke, I say, I get to be a spiritual doctor. I'm willing to sit and pray with you because I think that's better medicine than me trying to offer you a pill. And so in that, you know, I really do embrace my patients as people, and, you know, and I don't see them as just their disease or, you know, those sick people or those disturbed people. You know, I really try to see the good in them. And, you know, the beauty of the work is the longer you work with these people, I always joke, I do adult, you know, detox, withdrawal management, and some of these people are rather nasty. And usually by day 3, they go, I'm sorry. And I go, oh, I know it was the disease. Don't worry about it. And then we can usually have a good laugh. Most people, you know, I know it's the disease that controls them, not the, you know, it's not who they are. So a few acknowledgments. I just want to say this is I don't take any pharmaceutical money. These are the places I do work at. I do want to acknowledge Talia Brown. She's my program coordinator. She does wonderful work. She's shared some of these slides, and our Children's Hospital and our foundation for the support they give me. I also always like to acknowledge Boston Children's Hospital because they were kind of the grandfather in the field, and they shared a lot of their wonderful slides with us. And the Hilton Foundation, they do a lot of work specifically in substance. So today's objectives are really, we're going to work on a little bit of the overview of the disease of addiction, kind of some understanding of the brain. I want to discuss some of the novel areas of understanding that we're coming to, a little bit about medication specifically for opioid use disorder, and really the role of spirituality and the role of treatment. We're going to touch on that a little bit. And yes, we're going to do this in about 40 to 45 minutes. So the first part I always, and please, if there's questions, please put it in the chat. I always say save it for the end. Hopefully the slides answer, and we'll get some time to discuss them as well. So, you know, when we talk about addiction, we have to understand this is the way we understand addiction is the primary chronic disease of the brain: reward, motivation, memory, and related circuitry. It's a dysfunction of these circuits that lead to characteristic biologic, psychological, social, and spiritual manifestations. This reflects in the individual's pathologically pursuing reward and or relief by substance use and other behaviors. It's characterized by its inability to consistently abstain, impairment in behavior control, craving, diminished recognition of significant problems with one's behavior and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. So I always say, we talk about it in this disease, we look at really our consequences of our usage. So we know when we look at the cause of addiction, we know there's genetics, we know that there are environmental triggers. Genetics factors account for about half all likelihood that an individual will develop addiction, the highest being father to son seems to be the highest. Environmental factors interact with person's biology and affects the extent to which genetic factors exert their influence. Other contributing factors we know is the presence of underlying biologic deficits in the function of the reward circuits, repeat engagement in drug use or other addictive behaviors, cognitive and affective distortions, disruption of healthy social support, and problems in interpersonal relationships. Contributing, we know trauma or stressors that overwhelm individuals' coping abilities, distortion in meaning and purpose of values that guide attitudes, thinking, and behavior, distortion in a person's connection with self, with others, and with the transcendent, God, and high powers. Presence of co-occurring psychiatric disorder in persons who engage in substance use or other addictive behaviors. When we look at the disease of addiction, we know that these are the most common co-occurring disorders. We see anxiety, bipolar, depression, trauma and PTSD, schizophrenia, and antisocial personality disorders. According to SAMHSA, people with mental health disorders are more likely than people without mental health disorders to experience alcohol or substance use disorders. So I always like to start with the old school because I like history. So this is one of my favorites. This was the original kind of model design for how we looked at the disease of addiction. And basically for everything I just talked about, we talk biologic, psychological, social, and use. And there was this belief that if you had the right combinations of these events occur to you, you would turn that brain switch off, or excuse me, turn it on, and you would become addicted. And so the theory was, oh, all I got to do is fix those things, turn the switch off, and mission accomplished. It's all good. You're good to go. Good luck to you. Everything will be fine. And what they kind of then decided a little bit later is, it's not that simple. And they added this concept of relapse. And so when they looked at relapse, they talk about stress. They talk about triggers, and exposure to primers. As for anybody who's ever been involved in AA, I like to talk about people, places, and things, or the mnemonic HALT: hungry, angry, lonely, and tired. When I have a patient that's relapsed, I say, which of those things did you fall into? And they're usually pretty good about saying, yeah, I fall into one of those things. It's not that I just used. This is the work of Nora Volkow out of the National Institutes of Drug Abuse. If you're ever interested in learning more on the substance of the brain disease, I recommend her TED Talks. She's a wonderful speaker. And if you love history, her grandfather was Leon Trotsky, if that doesn't ring a bell. He was one of the heads of the Russian Revolution. Everybody knows of Stalin, but there was also Leon. And then he basically got kicked out, fled to Mexico. And so the funny story is, or I don't think it's funny, but I shouldn't say it's funny, but I always think it's interesting when she refers to her alcoholic or alcohol use disorder grandfather who committed suicide. She's talking about Leon Trotsky from the Russian Revolution. So her model kind of talks about a little bit differently than what the previous model, and this is kind of the way I look at it now, is this idea that when you first use that was your choice. But after that, the brain changes. So basically, the first time you use the drug, you have a response. You either binge, you have intoxication, and then you start having withdrawal and negative effects, which only leads you to use again because you don't want to be in that position. So then you become preoccupied, you anticipate usage, and you go back and use. And during that whole period of time, the neural circuitry of the brain is adjusting to the new chemicals. And so you're changing how your brain functions. You can't function without these things. And so you kind of keep using. So you go through this kind of violent cycle where you use to get feeling better, and then you start getting sick. And then what ends up happening, unfortunately, specifically with opiates, is you can build tolerance and dependence. So the amount that you used before doesn't give you the same experience. And then you keep using so you don't get sick. So a lot of my patients, I say, do you remember getting high? And they said, yeah, that was a long time ago. I don't get high. I just don't want to be sick. And honestly, with the age of fentanyl, that's why you're like, why do you keep hearing about all these people passed out in their cars or at the fast food restaurant in the bathroom? It's because, unfortunately, the stuff that's in our communities now is so not good, to say the least. It doesn't last very long, and so they use and they don't feel like they're sick. And when I mean they feel like they're sick, think of like having the worst case of the flu you ever had. They feel better and they go, hey, I can go have a normal life. Maybe I'll go get some food, and then they go use, and then they're literally waiting in line, and all of a sudden they literally feel like they have the flu again, and then they go and use, and that's where you get into hearing these horrible stories about people, being passed out in automobiles and restaurants and things like that. So, it's that preoccupation. They just don't want to go back into feeling bad, and so it just changes the brain completely. So in the old days, I always like to say this is how we used to make the diagnosis. We used to talk about substance abuse and substance dependence, and you had to have so many of these consequence-related things, either physical or emotional, and basically, I won't go into too much detail about it. We kind of got away from the use of abuse and dependence because it implied kind of a safe level, right? If I'm not abusing my drug because you said 4 times a day is abusing it. Well, I only use it 3 times, so I don't really have a problem. And you go, it's not about how much you take or how little you take or how you take it. It's really about, are you fulfilling your obligations? Do you use despite knowing that it's causing problems? And do you have tolerance and dependence? Do you need to use because you're afraid of having withdrawal? It's all these other things, but not saying, hey, I don't have a problem because I don't fit your criteria. We've kind of liberalized the criteria, and I always say it's really about how are you engaged in your community, how are you engaged with yourself, and is this the person you want to be? So looking at these criteria. These are just kind of a general overview. These are all the hormones in the brain that kind of are involved when we use a substance. It looks big and confusing. Don't worry, it's really not. There's really what we're talking about is dopamine and serotonin. And really dopamine, when you really deal with most of the drugs of abuse, we're dealing with dopamine. So to kind of put that in perspective, and I talk about this with my patients all the time, I say, we all make dopamine. It's our natural happy hormone. And you can see this is just kind of giving you an idea. If you eat or you're active in sexual activity, these are your natural levels. You make about 150 of it when you eat something you enjoy. Sexual activity gives you about 200. This is normal. And what you've done with your substance use is you've hijacked the part of the brain that does the reward. So, I mean, these are some older slides. If you look, amphetamines, where I told you food gave you about 150 and sex 200, amphetamines give you something closer to 1,000. Cocaine gives you somewhere between 300 and 400. Nicotine, over 200. Morphine, and we're not even talking about fentanyl, was somewhere in the range of 200. These are older slides. So I say there's nothing that I can offer you in the form of a medication that can compete with this substance that's going to override the system. And so, but you have to look at yourself and say, so what do you care about? Do you care about trying to reach that level of high when you're going to lose the things that you care about most? And I'm not talking about your job. Usually job is the last thing that gets sacrificed, but your relationships with people, your faith, your community, all the other things, those are the things that I try to focus on. Was it worth the moment of pleasure to give up everything else? So when I talk about substance use, I always like these. There's a couple slides I have like this. This was a couple of years back. These people made the national news. This is how I look at the disease. You go, what a beautiful picture, right? I mean, come on, 2 people, they're kissing, they're clearly in love. And then you take a greater look at the picture, and what do you really see? Are those trees? Yeah, those are trees. These people got in trouble for this photo. This is an infinity pool, I want to say in Belize, and it's about, I think it's like 60 or 70 feet off the ground. Those are the top of trees. And so they said, when they said, didn't you know you could have dropped this woman you loved? And the guy's response, their response was, I knew I had her. Well, that's true, you have her today, but how many times can you try to take this photo until you drop her? And then was it really worth it? I think the kiss would have been fine without the risk part of it. So, but that's kind of how I look at it. You're willing to take the risk to enjoy the pleasure. Same thing. At the same time, those people's photos, and they got kind of antagonized by communities. These people came out. This is like somewhere, I think in Sri Lanka. Same thing. Beautiful kiss. Are those trees? Yes. This is actually the side of a cliff. And again, same thing. When these people were approached, why would you do something so dangerous? Their response is, well, the train was going slow. Again, I don't think you need to add the risk factor to enjoy life. So that's kind of a general view of kind of some of the models. There are kind of some novel areas that we're kind of looking at, and it's something we kind of talked about before, but I'll kind of move into these things. We talk about the basic brain development. What you're seeing here, the area marked as the nucleus accumbens And the ventral tegmental is kind of your reward center. That's where the dopamine kind of gets processed. It's the part that kind of gives you pleasure of your brain. And then looking at the development of what's called the prefrontal cortex, that's the front part of the brain. And what we know is when you look at brain development, the nucleus accumbens, the reward part of our brain, develops very young in life. I mean, that's the part that really guides us in our reward and taking risky behavior, because you go, I want to enjoy the benefits of risk. But the prefrontal cortex, which is the final part of brain development, doesn't actually finish developing until age 26. And so I always say you have a very active desire for a reward, but you may have because of your substance use, depending on when you started, you impaired the development of the frontal cortex, which is kind of your higher function to say this is a bad idea. You may have impaired that. And so that's why we really talk about in recovery, we say the goal is to try to get the reward center to calm down and try to help you develop your prefrontal cortex so you can make some good decisions. So I always describe the brain very simply. I go, for you, your reward center is kind of like the devil on your shoulder, whispering in your ear, telling you, hey, let's do these things. The prefrontal cortex is that little angel on your shoulder that says, hey, we've got things to lose if we make this decision. And it's kind of, what I always say is in treatment of substance use, the goal is to cool the reward center and get that prefrontal. And I say between those two things, I hope you find peace. And that's kind of how we aim treatment and so forth. So again, this is just a kind of a slide just saying, look, all substances go to that part of the brain. So when I talk about opiates, my patients say, look, I have an opiate problem, but yeah, I drink alcohol, or yeah, I use marijuana. And I go, how I ask you about all those substances? They go, yeah. I go, guess what? I don't care about a single one of them. I care about what it's doing to your brain. It all goes to the same fire. And I said, fire will burn if it's diesel, if it's gasoline, if it's paper. Fire doesn't care what causes it. It just wants to burn. So I go, you say you have a problem with heroin. I say, guess what? The alcohol could make the heroin become a problem again. So that's why so many of us talk about abstinence from all substances, because we know that, unfortunately, it could affect the brain by turning on that which you thought you had taken care of. So again, talking about those novel concepts, this is that medial oval frontal cortex, the idea that you have the reward center opposed directly by that frontal cortex, which wherever your substance use started has impaired the higher function, the good judgment in your substance use. The next thing I thought that would be kind of entertaining, and I wish I could see hands, but I can't do it, is there's something we talk about is called, these are some of the novel ideas, is people have probably heard of reward systems. So this was a study that basically said, and so when we deal with substance, we really deal with reward systems, but we really deal with something called anti-reward systems, and I'll explain anti-reward in a second. So I always say, imagine, I'll be pretending like you're raising your hands. I want to play a game with you for a minute. The game is very simple. I'm going to give you $250. No questions. That's it. I'm going to give you $250, or we can play a game. Here's the game. You've got a 25% chance of winning this game, and if you play the game for that 25% chance of winning, I'll give you $1,000 instead of $250. But here's the deal. That's only a 25% chance of getting 1,000. If you lose, which is you have a 75% chance to gain nothing. So the gamble is 25% chance, you roll the dice, you win, you get $1,000, or 75% chance you get nothing, or you can just take the $250. If I was to count your hands, I'm sure most of you are probably leaning towards, you know what, I'd rather not take a risk, I'll take the $250. And the study pretty much found that 84% of people would rather take money rather than the chance of not getting anything. When we deal with substance use, we see that they live more in the anti-reward system. So people say, so what's the anti-reward? So the game now changes. I will tell you right now, I'm going to take $750 from you. That's your option. Now I'm going to offer you, you're not making money this time. Now I'm going to say, okay, you're going to lose $750, or we can play a game. The game is you got a 25% chance to lose nothing. You'll walk away not paying anything. But if you lose this game, you have a 75% chance that you're going to now owe me $1,000 instead of $750. If everybody, so who wants to take a sure loss of $750, or who wants to risk the chance of of either walking away paying nothing or a 75% chance of losing $1,000. I'll pretend that people are raising their hand. Guess what? Same thing. People tend to rather gamble rather than say, hey, if I'm going to lose, 1,000 versus 750, I'd rather take the chance of not paying anything. And so this really, when we look at the disease of addiction, they really live in this anti-reward. They know they're going to lose. So the question is, how big do they lose? And maybe, just maybe, I can get out of this, right? The chance that I might not pay any type of harm. And so that's really what we see. We see human nature. People avoid risk to ensure gains. They take risks to avoid definite losses. And psychology will always trump probability. The final kind of novel concept which we see with substance is this concept of interoception. I really like this. I focus a lot with my patients on this. These are kind of the insula of the brain where we take normal, what we call somatic signals, and give them meaning. So, to use myself as the example, being in this room with you all today, I can feel a little sweat on my forehead. I probably should turn the heat down a little bit in my house, make it a little cooler. It's making me a little uncomfortable. I can feel a little uncomfortable in my stomach. I probably know in an hour I'm going to need to eat something, and my mouth is a little dry. I probably should have a glass of water, probably sooner rather than later. These are normal things, and you and I know how to kind of push them in the back of our mind, right? Because right now I'm in this presentation. I don't have time to adjust the temperature. I don't have time to step out of this room and go get a drink of water. To a patient with substance use, the substance changes this relationship of these signals. So I always say, for them, that little bit of uncomfortable sweat on their forehead is the worst experience they've ever had. They stub their toe, it's broken, and it's the worst pain they ever had. And they feel the need to act on these signals very quickly. And so in that's kind of that coping. They don't know how to adjust to the signals that are normal that have now been altered by their substance use. And so those are kind of the novel areas that we're kind of looking at, and these are kind of areas I try to help my patient understand that there is another path, and there's a way to kind of deal with some of it with coping and motivation and meditation and things like that. When we deal, kind of changing gears, when we deal with FDA approved medications for opioids, people go, gosh, there must be a lot we can do. Honestly, there's very little. There's only 4 medications that are FDA approved. What that means is these are the medicines specifically designed for opiate use disorder. Everything else that you hear people may be trying and doing all off label. It's all kind of Wild West medicine, so to speak. But so when we talk about something called Naltrexone, and we'll go into a little more detail in a second. That comes in 2 forms. It comes as an oral and a long acting. That's what we know is Vivitrol, the injectable. There's buprenorphine or Suboxone or Subutex, if you've heard of that before. And there's methadone, which methadone's the original one from the 70s. Then you have to look at how you get it in the body. That's just saying routes of administration. You can inhale things, IV, transdermal, sublingual, rectal suppositories, you name it. We have to look at how to get these medications into people's bodies. Again, these are the 4 medicines. So kind of the way we first look at it is very basic. If this is your brain, this is the connection between the opiate, heroin, fentanyl, Percocet, and the connection to the brain. So what you're seeing is the opiate connects to the receptor in the brain, and you get the desired release of the muse activate, and you basically get the feeling of either, if you're having pain, improvement in pain. If, for example, Muse does some things to make you constipated, that's why a lot of patients suffer with constipation. It's basically, it gives you the relief you're looking for and activating on the brain. So when we look at methadone, and methadone's the original thing, it's what we call a full activator on that receptor. It basically, if you're using Percocet, heroin, any of those things, methadone is a much longer acting version of the same idea. It's what we call a full agonist. It works on there the same exact way those things do. The issue is so you can have respiratory depression, you have the risk of overdose. So when people think about methadone, you hear about methadone clinics. Why? Because it has to be highly regulated. As one of my patients once described it, it's golden handcuffs. You're basically going there to get your opiate for the day. And the problem is you will go there every day for the rest of your life. You have to show up, you have to take it in front of them, and basically you have to read like a note card to make sure you're not cheeking the medicine, and you have to get up. So if you ever know where one is near your community, you'll see lines forming at 6 a.m. in the morning, 5:30 in the morning. It's not a good lifestyle. It's kind of what we usually think of this more for a lot of people who have a lot of the end stage disease. So it's not a great lifestyle. Most of what people hear about now is Suboxone. Suboxone can be prescribed by a primary care provider. It doesn't have to be in a special controlled clinic like methadone does. You just need to have a special waiver license. It's what we call a partial agonist, meaning it still binds to that receptor, but it doesn't do the same thing like methadone would. It only works part of the way. So what it does is it'll take you out of the withdrawal symptoms. It will kind of level you out, but it doesn't give you any chance of euphoria. And because of that, it doesn't also have the respiratory depression component of it where you could stop breathing. So it's a little bit different. The problem is most of my patients will tell me, and I've learned, is it didn't do what you thought it was going to do. They go, no, I was hoping that it would do more like the heroin or the Percocet or the, and I go, yeah, it just kind of makes you back to normal. Normal's not that exciting, is it? They're like, no. And then you have to remind them of all the things they could lose if, you know, if they went back to the way it was, you know. And a lot of people, that's all they want. They just didn't want to be sick. And so they're, you know, they have to work their recovery program. And this is just an idea. Again, this is just showing that opiate receptor binds and you have no withdrawal, no pain. What you're seeing, those little dotty things, that's buprenorphine. It doesn't quite, it fits in that receptor like a locking key, but it doesn't quite look like the same key. So it kind of does its job a little bit, but it doesn't do the full job like the opiate would. It comes in lots of forms. It comes as pills and sublingual strips. We do now have a long-acting injectable, which is really nice for a lot of patients who have issues with compliance, not taking their medicine. We can inject it into them. And they do make a subdural implant, which so basically you could put in, like, I think it does 3 to 6 months. I don't know anybody who really uses it. It's very difficult to get approved with insurance, and most patients don't want something implanted in their skin. Naltrexone is the final one. This is very similar for those who, you know, especially in this group, have experience with Narcan. Naltrexone is the long-acting version of Narcan. So what this basically does is it acts as a blocker. It basically goes to that same receptor and it turns it off. So I always say the analogy I explain to my patients is, if you think as opiate is the key and the receptor is the lock, I'm going to put a key in the lock and I'm going to break it. So I turn the system off, and that's what naloxone. So it basically blocks the receptor. It comes as a pill, so you can take it once a day. We do an injectable. We do those shots every 28 days. So again, same. This is just showing that again. If that same receptor, I'm going to put something on that receptor. Think again, the other analogy I use, it's like the oil well. I'm capping the well so the thing won't keep, you know, spilling. And again, this is just explaining it comes in pills and so forth. Kind of the final part, and this is why I'm really thankful for this community, is I always share this slide. There was a study done, you know, where they looked at medical students and house staff of a detox place, and they said to the patients, and they said to the house staff, and they said, and the residents or the med students, and they said, what do you think helps people get better? And so, you know, and they kind of listed what they thought. And what I always say is, what people think is, you can see what the people think that patients who need recovery need is housing, government service, medical service, outpatient treatment, jobs. And then at the bottom, you start getting to community, trusting people, inner peace, God, spirituality, AA. When you ask the patient what they need inner peace. They're looking for God. Yes, they need medical services, but they're looking for something bigger. They're looking for spirituality. Those things are high. Job is all the way at the bottom of it. So I always say the medical community, and that's why I feel blessed in what I do, is I respect my need for spirituality. I consider myself a spiritual doctor. When those medicines that I just shared with you, when the patient said, is this going to be what gets me better? I go, no. I said, it's going to help you so that you can find peace. And that's all I'm offering you, but you're still going to have to work a recovery lifestyle. You're going to have to surrender to something higher. So that's kind of where I kind of come from. So they go, so you're not telling me to take the medicine? I said, no, I want you to take the medicine so we can help you become more stable in your lifestyle, so you can realize how to make better choices in life. But if you think the medicine's going to keep you safe, it doesn't work that way. I'm sorry. The other thing I thought that would be good to share with this group is, you know, a lot of people say, I'm just not spiritual. I'm not a religious person. And this was an interesting study where they just asked patients, how do you define it? Or it looked at multiple studies and kind of said, what is the core make up spirituality? How do we identify what we define as spirituality? And so I like to bring in relatedness, interpersonal relationships, transcendence, recognition of the transcendent dimension to life, humanity, the soul, meaning and purpose, authenticity, truth, values, importance and worth, non-materiality, non-religious, opposition to spirituality identified with religion, that I'm not really, wholeness, holistic wellness, wholeness of health, self-knowledge, creativity, and consciousness. So I always say, when you're trying to approach somebody about the concept of spirituality, your definition of spirituality could be different from somebody else, but the idea, and you can kind of embrace that. My definition's a little bit different than yours, but I think we both want the same thing for you. I think you have a spiritual nature to you. It's just been buried down deep in your usage. So I always say, be flexible in the definition. It can be very helpful. And the final thing is, for those of you who have worked 12 steps of narcotics or AA, they go, again, I'm not spiritual. I go, good. If you're that worried about it, God's only mentioned 4 times in it. But that being said, it's that spiritual awakening is what we're asking from you. If you look, the things I've kind of underlined are those concepts of the spirituality. Yeah, there's some inventory and admitting when we're wrong, but it's really about surrender and embracing that you deserve better than your addiction. And that's kind of where I focus my patients. I go, you think it sounds like a spiritual document. I'm telling you that if you really try to work a recovery lifestyle, what we're asking you to do is realize that you're not the center of the universe, that you can put your faith in others, that you can put your faith in a higher power and you will get better. But you've been trying to do this alone. You've put yourself in this hole. And you keep thinking if you just dig deeper, you're going to get to the other side. People always say you're going to dig a hole to China. No, you're going to hit molten lava way before you hit China. And then you won't be here anymore. So the idea is you just have, learning to embrace that idea of surrender and the greater whole. Please give it a chance. We're here to help you. So my final part is I found this quote. I think it's a beautiful truth for me. You see heroin, I see low self-esteem. You see cocaine, I see fear. You see alcohol, I see social anxiety. You see track marks, I see depression. You see a junkie, I see someone's son. You see a prostitute, I see someone's daughter caught in addiction. You see self-centeredness, I see the disease. You see a pillhead, I see over-prescribing of opiates. You see someone unwilling to change, I see someone who hasn't connected with them yet. You see denial, I see someone hurting. You see someone nodding out, I see God showing us they need help. You see the end, I see the beginning. You see a dope fiend, I see a future success story. You see them, I see me. And changing gears, this is for Akron children. If anybody would like flyers, please let us know. Also, I'd be remiss especially in the COVID epidemic and everything's going to virtual. Please remember that it's really important to get your health screenings done, your well checks done. There's, unfortunately, everybody's really, as we keep talking about COVID, we're really missing. There's lots of other things, and we know that unfortunately, suicides are up, overdoses are up, and we really need, taking care of ourselves. So I really would advocate. If anybody needs flyers related to that, we can also get those kind of flyers too. We have for wellness checks. This is our phone number if we need to be reached, and I think we can take it open to questions.
Thank you, Dr. Goldman. That was a great presentation, and I'm really happy that you were able to go first, because in case you didn't notice, and that's what this is about, the things that people are not noticing because of the COVID epidemic right now. And just really want to thank you for your presentation. We do have a couple of questions for you. One person wanted to know that there was a woman that you referenced that that should be listened to on YouTube. Can you provide that name?
Sure. Yeah, really simple. Her name is Nora Volkow, Volkow. You can also go to National Institutes of Drug Abuse, NIDA, N-I-D-A. I believe it's nida.gov. She is their, I just went blank on the title I want to call her, but she is Nora's all over the place on that website because she's their she's the head of NIDA, so she even has like her own little blog. She has links. You can find TED Talks. I think she's a wonderful. She's come and spoken to the National American Society of Addiction Medicine. She's a wonderful. She's really is the advocate of the brain disease. So she is a wonderful person to listen to.
Thank you. And then the other question is the question I had in listening to your presentation. And I remember earlier on, you had talked about the prefrontal cortex and development of that part of the brain. Is there some connection? And then at the end, you talked about like the inner peace and the spirituality. Is there some connection between inner peace, spirituality, and the development of that part of our brain?
I think it is. I think, you know, from my point of view, it's that because the frontal cortex really does that higher function, right? It's the part that says you have something to lose. Well, what do you think you're going to lose, right? I mean, you know, it's the part that says there are consequences, and I think, you know, it's kind of, you know, it's, you know, what you're dealing with is that you know, when you deal with the reward center, if you remember Freud talked about the, you know, the id and the super. It's kind of that higher functioning, and really the problem is people have to find peace with that. Like, how do I deal with all these things and cope? And the answer is you have to make, you know, that's where you get into the spiritual component. You have to believe, again, you're not the center of the universe, which is a very hard thing for people in substance. They get so wrapped into everything going on for them that they just kind of miss that we're all here to help you, and in that, God is here to help you. That there is this power that exists. I believe in that. You know, it's hard. A lot of people, especially depending on when their substance, they may not have had that spiritual awakening to realize, you know, where they need to be. You know, you know, there's a lot of people who say, I just come to church, but you never really had a spiritual awakening, you know, and realize that there's a community that loves you, you know. So I do. It's kind of getting them there. Exactly calling it that part of the brain, it's hard to say, but I do believe these two, there is a role. So.
Awesome, thank you. Another question we have that has come in is, does the patient feel sick because of withdrawal or because the brain has changed?
The answer is the withdrawal is the brain change. So the answer is yes. You know, once you've developed what we call tolerance and dependence, meaning the drug gives you a certain sense of relief and pleasure, that's the rub of specifically opiates, is once upon a time where you had to have so much of that chemical in your brain, you've overshot that mark. So you got used to the high experience of having higher levels, but the rub is the brain adjusts. And so the problem is you need more and more of the substance to try to get back there. And the problem is that's unsustainable, right? I mean, there's just too many problems. So the problem is once you've made all those receptors in the brain and then you don't have the substance or enough substance to kind of smooth the brain out, you go into withdrawal. And so that's what happened. The brain is sick because the brain's saying, where's that chemical I need? And I need X amount of it. So you get sick.
That's a great question. See, I think there might be one more coming here. It looks like someone's typing. Give it a second to show up. We do have a time for a couple more. Here it is. What would be your top 2 tips for people of faith to support someone in addiction? That's an excellent question.
Yeah, I think the first thing is realize, you know, that the disease is you know, I use a lot of analogies. The person in front of you is not the person who they once were. So when they're, you know, and just so you have to give them love. You know, it's that kind of ideal. A lot I talk to people about grace, this idea that, you know, you have to forgive what they've done to move forward. You know, a lot of, especially patients in early recovery, if they've been in multiple times, they're like, I know I'm back again, and they have they have no self-worth. And so understanding that they do have value, that there is a plan for them, that God loves them, that you love them, that you know that this is the disease, and that if we work together, we can get better, you know. But when you say the hurtful things that you say, realize that's not who they are. That's what the disease made them, and we can get them better. And that's what they need. They need to know that they're not alone in the universe.
That's great. Great stuff. Let's see, we have another one here. The chart you shared about what medical professionals think people need versus what the patient says they need seems to flip Maslow's hierarchy of needs on its head. Your perspective?
I don't know. Maslow was looking at people with substance use, but again, but if you look at it, you are correct, right? It's looking at people who think you need help, think you need a job and you need a place to live. I mean, all the hierarchy things, you're right. And these people, they don't, because I think the greatest thing I could try to pass you is there's so little self-worth. There's so much mental health where they're stuck in this hole. You want to give them a house, they need to get out of the hole first. Then we can put them in they're living in the hole. Let's get them out of the hole, and then we can put a roof over them. So, yeah, I mean, a lot of time that's how I look at it. So you're right, actually, yeah, that's all. We look at it and say, if you just had a house and a job and everything, we can put it all back together. But it's not addressing their underlying needs.
Absolutely. Here's the next one. Is it possible for the brain to go back to a normal, healthy state after smoking pot during the age span of 18 to 25?
So that's a good question, and the answer is there's a bunch of longitudinal studies that have looked at this. If you've had IQ, so for example, they've done studies. My favorite is the Dunedin study, which is now basically been looking at these people since they were born, and then there were a group that ended up having cannabis use disorder. And the answer is some of these people struggle with IQ loss, and it does not look like you get that back if you stopped using. So if the IQ loss has already occurred, probably not. The other thing is what we see is we have an increased rate of depression and schizophrenia. When we looked at some of the brains of patients with significant cannabis use, some of the brain looked like it thinned out, and we're not sure you ever get that back either. So that's why the cannabis use can have some schizophrenic appearance to it too. So the answer is, I don't think we put it all back together. I think we do better. And to be honest, but I don't think we ever fully get. My opinion is I don't think we fully get it back. And it's the same thing, honestly. Even when we talk about addiction as a disease, right? I tell my patients, I go, that reward center is hijacked for the rest of your life. It's always in the background. Like I said, I use the devil. The devil is a great analogy for these people. I go, the devil is patient. The devil is waiting, and it doesn't take anything. So that's why we focus so much. Yes, we talk about medications, but we talk about the abstinence lifestyle. As there's a part in the big book talks about, why can't we be social drinkers? It's just that's not a possibility. That's not a good way to live. So
that your last statement kind of leads into one of our next questions, where it talks about how come we can't be social drinkers. And one of the questions we have is can you speak to the correlation between like sickness and sin?
Probably not comfortably, as I believe in sin, but the real question is it worth putting that model onto somebody in their early stage of recovery? I mean, part of the recovery thing is to make that moral inventory. I believe very strongly in the AANA model, is doing that fearless moral inventory. And that's where I think maybe more grace, but focusing on the sin that they've harmed to other people. Again, I think the first phase is acknowledge where people are in their recovery and helping them. I mean, there will become a point where you're going to have to address the things you've done wrong, to move forward. And that's kind of built into the NAAA model. But to start off with, you're a sinful, that doesn't get you anywhere. If you look at recovery stuff, people always try to shame people into recovery. Shame will probably work for a few weeks. After that, they throw up their hands and say, I don't care about that either. I'm a worthless person. I am, they'll start embracing the moniker. So while I think you're going to have to address it, I would not recommend trying that in early recovery. And I think that's part of that inventory. And I would say take a look at the 12 steps, because it's built into the 12 steps as you move through the steps to kind of address what you've wronged people, to apologize. And then ultimately the plan is you have to pay it forward. You have to help somebody else.
There's a time and a place.
There's a time and a place. But I can tell you right now, I've had people try to say, you've done all these bad things, and the person will just shrug and go, all right, that's who I am. I'm worthless, and live a worthless life, you know.
And here's the last question, and that is, are there specific ages that Akron Children's treats?
Yeah, so our substance program is designed for 18 and still in high school.
Okay.
So that now the phone number I shared and the thing that does not, if you need help, call us. We try to set people up with our community partners. We consider ourselves part of the greater community. So we have, to give you an idea, we get referrals from employees. We get patients who, you know, I saw you had a thing. I have a friend. We will try to help coordinate care with people, but our program specifically at this time is for under 18, and those still in high school. So if they're 18 and in high school, we'll still see them. So
awesome. Well, once again, thank you, Dr. Goldman, for your presentation. Thank you for your time. I also want to thank Bishop Joey Johnson, also with the House of the Lord, for partnering with Summit County Community Partnerships. If you had noticed, when I mentioned earlier, this is fully funded with the grant from OMAS, the Ohio Mental Health and Addiction Services Agency, and we're going to continue this conversation going forward for the month of September. So every Friday, there will be a different speaker through the month of September, which is actually September is Recovery Month. So this is a good month for us to have these conversations. Next week, we're going to have the In Case You Didn't Notice webinar. That will be September 11th from 12 to 1 with Myron Lewis. He's a licensed independent chemical dependency counselor, and the topic will be fears and concerns which can hinder successful recovery. So you will need to go ahead and register for that on our website, same place you registered for this webinar. Also, you will receive this webinar was recorded, so you'll get an email of that along with an evaluation, and we really appreciate if you fill the evaluation out, give us some feedback, help us make this better, and also you will get a certificate of completion via email as well. So I want to thank everyone for attending. Once again, I want to thank our presenters, and we'll be back next week, next Friday at the same time, same place, 12 to 1, as we continue the In Case You Didn't Notice series. Thank you, and have a good weekend.